Hello, this is Rajesh Vedantan from the NYU Grossman School of Medicine. Happy to be here with you all today, and I will be presenting to you a practical application of implementation research theories, models, and frameworks. No corporate disclosures. These are some of the federal, US federal, or American Heart Association grants I might be referring to during the presentation. So as has been presented to you on multiple occasions, there's a very large knowledge practice gap with respect to cardiovascular disease. Less than 10% of individuals who have had a stroke and less than 15% of individuals who've had a myocardial infarction are on evidence-based therapy worldwide. So there's obviously a huge gap between what we should do and what we actually are doing. This is where implementation research comes in, which is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, essentially to try and close that evidence practice gap. And the idea behind implementation research is that we take what has been proven to be known here and move it along the translation pipeline into actual implementation, sustainability, dissemination, scale up, and scale out. There's several criteria for a good theory, as has already been discussed previously. The clarity of theoretical concepts, the clarity of relationships between constructs, measurability, testability, being explanatory, describing causality, achieving parsimony, generalizability, and having an evidence base. And there are some very nice resources. This comes from the University of Washington of why and how to use different theories, models, and frameworks in implementation research. I've listed here at the bottom this website from the University of Washington that really does a nice job of showing how you can use these different theories, models, and frameworks as process models to guide the entire process of doing an implementation research study, how to understand or explain what influences implementation outcomes, so determinant frameworks, classic theories, and implementation theories. And then finally, frameworks that we can use for evaluation. I've come up with my own cartoon to describe what I like to describe as a transdisciplinary approach to implementation research, where we identify the problem, analyze its determinants, develop solutions, implement the interventions and strategies, and then evaluate outcomes. This transdisciplinary process requires involvement from experts in qualitative research, quantitative statistical research, colleagues from economics and business community, as well as colleagues from the IT and human performance engineering sectors. And what I'm going to talk to you about today is how our team in Western Kenya has used different theories, models, and frameworks in the context of one of our projects called STRENGTH, Strengthening Referral Networks for the Management of Hypertension Across the Health System. So if you go back to my cartoon, how do we identify the problem? And what we realized in our setting in Western Kenya is that we had developed a very advanced cardiovascular care at the tertiary referral hospital, a cardiac care unit, advanced cardiovascular outpatient consultation services, etc. And we had actually developed some very nice innovations in the rural primary clinics and dispensaries as well. Task shifting, mobile health, consistent secure drug supply, combining microfinance and other social determinants of health into care delivery, etc. But the challenge was that the gap was that if we tried to refer someone from the primary up to the secondary, up to the tertiary level, that there was no guarantee that the individual would actually make it from the primary center to that, let's say, tertiary hospital. That if I sent somebody with complicated hypertension or difficult to control hypertension, I had no idea if that person would actually arrive at the hospital or the tertiary clinic, what was done to that person at that time, what treatment recommendations were done, what I should do if the person came back to me. So these referral networks across these different levels were quite weak. And so then we had to try and analyze the determinants. And here we can think of macro and micro determinants, think about overall context, structure, and obviously individual agency as well. So there are multiple levels of determinants, ranging from the individual or the family through the community, all the way up to the national or state level. And what we decided to do was to use the precede-proceed framework to help guide us with respect to this exploration of the determinants of these challenges with the referral system. This is the classic precede-proceed framework from Green and Kreuter from over 20 years ago. These formative assessment phases followed by implementation and evaluation. And here was the manifestation of that precede-proceed model for our strength study. And these initial phases of doing different types of assessments is what I would like to focus on today with respect to analyzing the determinants of these referral challenges with referral networks. And one of the things that we did was we actually did process mapping, where we actually followed a patient through their referral experience, both at the clinic where they were being referred from, as well as the clinics that they were being referred to get a sense of the lived experience of these patients and what was, what their experience was at these different facilities. And we realized that there was a lot of waiting, and also a lot of paperwork, different papers that they had to fill out, and essentially a lot of time before they actually got to see the provider or the clinician. That was one of several different types of methods that we used. We used qualitative methods using community gatherings and focus group discussions, interviews with key stakeholders and administrators, and we triangulated all of these data from different sources to figure out the exact determinants of these challenges with referral networks. Then we went on to the next step, which is about developing solutions. And just as an aside here, with respect to intervention and strategy selection, there are many different strategies or interventions that can be chosen, and they're not all mutually exclusive. Some are patient-focused, some provider-focused. They can range from education to feedback and reminders, safety issues, organizational level change, economic strategies, policy and regulation. As I said, they can be multifaceted. What we decided to do was to adopt an approach of human-centered design to generate the solutions that we were going to test out. And here, just an aside about design thinking, which is really about trying to match desirability, meaning people's needs, feasibility, social, political, technological, and cultural, and viability, economic, sustainable, and scalable. And the idea behind design thinking is really to combine what we've traditionally learned with respect to analytic thinking, deductive and inductive reasoning, with abductive or intuitive and imaginative thinking to really sort of integrate all of this together. The basic idea is to think outside the box and to rethink the problem in order to rethink solutions. One of my favorite examples of this is the elevator bank problem. We've all been at the bottom of elevators, whether it's in hotels or hospitals or apartment buildings, and there's always a wait, and the wait can get very annoying. And there have been all sorts of engineering solutions that have been attempted using deductive and inductive reasoning and analytic thinking, making the elevators faster and slower making them more responsive, maybe starting them at floor 7 rather than all of them at floor 1, etc. But there's always a non-zero weight. So then someone came along and said, you know what, let's rethink the problem. Maybe the problem is not the weighting. Maybe the problem is the boredom. So let's address the boredom. So they put a mirror at the bottom of the elevator bank. Now all of a sudden, people are doing their makeup, they're combing their hair, they're checking out other people, and they're no longer bored. Now, if you look around at all of these very fancy hotels, almost all of them have these mirrors at the bottom of their elevator banks. Of course, the 21st century version of this now are these smart screens with news and weather updates. But the basic idea is the same, is to address the boredom rather than the actual weight. So again, this idea of rethinking the problem in order to rethink the solution. This is a little bit of a different example, and full disclosure, this was a picture taken in the men's restroom before I used the urinal. And for anyone who's been in a men's restroom, we all know that it's an very disgusting type of scenario and scene. Urine on the ground, it's really dirty, it's pretty disgusting. And there have been many solutions to try and get men to pee into the urinal and to be cleaner in the bathroom. Signs that say, please do not pee everywhere, keep the bathroom clean for the next use. Signs like this that say, don't pee on the ground, but pee into the urinal. And the challenge is none of these have really worked, whether it's that men don't like to be told what to do when they're in the bathroom, whether they're just spacing out and not really paying attention, it's unclear. But many of these types of solutions have not really been successful. So someone came along and said, you know what, let's change this to target practice. And they put a little sticker of a fly, a little bit off center in the bottom of the urinal. And all of a sudden it was like, hey, I have something to aim at and something that I want to hit. And what they realized is that this actually reduces spillage by over 80%. So again, the basic idea was to rethink the problem in order to rethink the solution. So we did our design process with respect to strengths and with respect to this referral network problem that I was describing before. We had design parameters from the study protocol as well as our baseline assessment that I've already described that were inputs into the design process. And we had ultimately in the end our design outputs, which is a scalable interventional model. And we went through various prototypes. And then we also did a lot of community-based testing, asking community members whether they liked the idea, whether it was a good fit, this iterative process of getting feedback and going from one prototype to another, with overall ultimately positive feedback with some persistent challenges, but in the process, being able to engage community, actually build capacity with respect to design thinking in this community, and really actually work side by side, hand in glove with program implementers and health system strengtheners to really sort of work in tandem and in parallel with health system development as well. And what we ultimately came up with was a combined intervention of peer support and health IT or information technology. The idea behind peer support was to have individuals who have hypertension, who have successfully navigated the referral process, serve now as peer navigators for their other peers and other individuals living with hypertension who may have challenges with the referral system, to be able to encourage referral adherence, to actually provide some very basic navigation, how to get to the maybe specialty clinic, how to navigate the campus of that specialty clinic, and to provide psychosocial support. On the health IT side, designed to be able to enhance communication between peers and clinicians, between clinicians at different levels of the health system, at different facilities, decision support for the peers. Then on the back end, being able to track whether the peers are actually visiting the patients, whether they're actually helping them out, create dashboards to see whether we are actually improving our referral metrics, et cetera. So these are the sort of two different components of the strength intervention that we developed in the process of that human-centered design process. Now, in terms of implementing the interventions, we're now going to set up a two-arm cluster randomized trial where we compare the strength intervention versus usual care follow up individuals for 12 months to look at both changes in blood pressure, cardiovascular risk reduction, and then referral process metrics, whether the referrals have happened or not, whether they happened in a timely fashion or not, et cetera. And here, just a quick aside about some of these trials that can be done in the real world in implementation research, as opposed to trials that are done in a very controlled laboratory type setting. Implementation research obviously happens in the real world. It's messy, it's pragmatic, whereas the more sort of controlled trials can happen in a much more tightly controlled setting. And there's been some great work done, the PRACIS 2 wheel, looking at how you can, as your own team member, sort of get a sense of, along all these different criteria, whether you score lower, meaning closer to the more sort of tightly controlled type of explanatory study, or whether you score higher, meaning that you're more on the pragmatic implementation, real world, messy, quote unquote, loosey-goosey side of the study. And these can be applied to various criteria, whether it's eligibility, recruitment, setting, organization, flexibility of the delivery, flexibility of the adherence, follow-up, primary outcome, and the primary analysis. And just visually to illustrate, generally implementation research will be more like on the left, where there's a lot more flexibility with respect to all of these categories and factors, and more tightly controlled, strict randomized controlled trials, clinical trials, will be more like on the right, where everything is much more tightly controlled. And again, these tables you've seen before, again, comparing pragmatic versus traditional trials, but there are many, many differences between pragmatic and traditional trials with respect to stakeholder engagement, the design, the different outcomes, the measures, sources of data, availability of findings, exclusion and inclusion criteria, whether you're looking for external validity versus internal validity, active comparators versus placebo-controlled, whether, again, the outcome measures, the length of follow-up and the intensity of the follow-up, blinded versus not, etc. Finally, in terms of evaluating the outcomes, there are several different ways to go about this. As has been shown to you before, implementation research and implementation trials are classically divided into 3 different hybrid types: hybrid type 1, hybrid type 2, and hybrid type 3. And the idea behind the sort of division is that hybrid type 1 generally is primarily focused on testing the clinical intervention while gathering process and implementation data. Hybrid type 2 theoretically is supposed to try and have co-primary outcomes of both the biological and the implementation measure. And then hybrid type 3 is really where you're much more interested in testing the implementation strategy, and the primary outcome is really the implementation measure. And then you're gathering data in a secondary fashion with respect to clinical effectiveness. The corollary to gathering all of these, or the process by which you gather these implementation measures, is a formal process called process evaluation. And the idea behind process evaluation is that you're really supposed to get a sense of context in which implementation is happening, the actual implementation process and the details of that, what is delivered, how it's delivered, who it's delivered by, whether you're delivering it with fidelity, at what dose, if there have been any adaptations to the delivery, et cetera. Try and get a sense, therefore, of the mechanisms of impact, then help explain the outcomes that you see. What we decided to do in Strength was to use what's called the Saunders framework. It's a fantastic framework that is really quite clearly laid out with respect to these 7 components of process evaluation. Fidelity, meaning the quality of the intervention, the dose delivered, the dose received, both the exposure of the participants as well as satisfaction, recruitment, reach, and context. And what you can do is take each of these different components and figure out what data collection method is most appropriate to measure each of these components. And I won't go into this in detail here. I'm happy to go into more detail during the question and answer. But each of these different components are using different types of data collection methods, ranging from field observations to focus group discussions, to written tests, to self-reports, to semi-structured interviews, etc. And so once again, just to return to this cartoon that I've mentioned before, I've hoped that I've been able to provide you a real-world example of how we've used the pre-seed proceed model to help identify the problem and analyze determinants, how we've used human-centered design to be able to develop solutions, how we've used an approach to pragmatic trials with respect to our cluster randomized trial, and how we've used the Saunders method for process evaluation. And thank you very much.